Hi guys, my name is Melanie Grant, and this is a quick video showing you about some of the selection of E&M coding when looking at the different key components for inpatient services and other services that are not office and outpatient services, as well as some of your basic identification on types of service and how to know what to select. Let's take a look together. Now, for the purpose of this recording, I will be using 3M in order to look at some of the tools and guidelines that are found inside of your CPT evaluation and management section. You can follow along using the 2021 or current year CPT codebook, or you can log into 3M if you have access. I've selected here some information that I find relevant, like when I want to just look up a CPT code, I like to select a patient that's simply other, not gendered as male or female, age 33, and I'd select my product for just looking at CPT codes. If you're using 3M as a code finder, this is a great way to go. We don't have to worry about pediatric or geriatric patients, or perhaps edits that apply only to male or females. However, keep in mind that 3M is used in so many ways outside of just a code finder. And so if you're using this in your office, there's probably a specific setup you will want to use. Now, some of the things I can do in 3M is I can look at a procedure, and I know I'm looking at CPT because it says CPT procedure, and I can have it guide me in my evaluation and management selection. I can select evaluation, and then I can say E&M or E/M or E and M, depending on how it's selected. And it can help me to identify the type of service. Obviously, if I'm doing a Medicare patient type of service, I want to look at some of the G codes that are found in the HCPCS codebook. Otherwise, I'll look at other evaluation and management services not part of the HCPCS G codes. Then I can select the type of service here. There's tons of types of services in evaluation and management care. And if you're not familiar with all of these, it's probably a good idea to take some time and identify what some of these are. In 3M, you have a couple of definitions that will give you information about what is included in a specific type of service. It's important when you're new to this coding area to look at some of these question marks and say, what is this type of service? And if you don't have 3M and you're looking in just your CPT codebook, there's a lot of descriptions and information on each of these types of services as in-section guidelines that will define these for you. Another thing I can look at in 3M is the current procedural terminology, or the actual codebook itself in an electronic format. This is good when looking at some of the guidelines because I can go here directly and look at the evaluation and management services and see the guidelines that are found from AMA inside of my CPT code book. There's other sections, of course, with different areas for appendices. And if you're not familiar with it, there's actually an appendix in here that will give you some guidelines on, or some clinical examples for Appendix C that shows you how to determine the level of service based off of some common chart examples. This is actually pretty cool, especially if you're not familiar with E&M selection of level of service. For now, I'm just going to look at the evaluation and management services under the AMA CPT guidelines. And I can see here that there are guidelines that apply to all of the services, and then there's specific guidelines for each type of service, depending on what I'm looking at. If I want to look at all of the services, it's also broken down. And this is just as it is shown in your CPT codebook, starting on page 1. Your CPT codebook, page 1 through 4, include your table of contents. And when we go to page 5, we have these exact same guidelines that you can see here on the screen. This is new in the 2021 code set because there's new guidelines for E&M selection for office and other outpatient services. We have some pretty detailed changes that are found in the guidelines. You can see this by seeing the little symbols indicating this is new, which are the same symbols for new and revised text that are found in your codebook. This table we'll get to in a moment. but it basically tells us that if your patient is office or other outpatient services, what the difference is between these services when looking at the main key components of selecting your level of care and comparing that to other services that you're used to if you've coded E&M before. If this is all new to you, it's not important as much to look at this right away, but when you get into the nitty gritty and you start coding, this is a very, very valuable table to reference and determine which type of service you're going to use. And of course, your visits for E&Ms are broken into different categories. And so you do have some guidelines identifying what some of those categories are, such as office visit, hospital visits, consultations. These are also referred to in many cases as types of service. Let's see. There's also a couple of definitions that are new, and in the evaluation and management guidelines for everything, they actually go into some really in-depth definitions later on when they start talking about the extent of the key components and some of the definitions found. For now, once we determine a type of service, one of the important questions we're going to look at is, are they a new or established patient? And this matters sometimes, but not all the time. Now, on Roman numeral 25 or XXV through Roman numeral 26 or XXVI, you have some tables that help you to identify information about your level of service, which identifies the requirements for certain key components, including statements on whether or not it's mandatory if the service is new or established, or if it's not mandatory and they simply say new or established, meaning either or. I've put together an E&M decision tree. This is just kind of a basic overview. It's nothing official or permanent, but it helps you to identify the type of service and what you're looking at. So if I have a decision tree where I say, what is the type of service? There's going to be a couple of them that I need to look at very unique guidelines before I continue on, such as your office and outpatient services, which should have their own decision tree based off of the tables that we saw already, with medical decision-making and time as their main components. If the service itself is preventative or time-based, or some of the non-face-to-face services that have very specific requirements, those are unique and they have their own guidelines that are really separate of most of your traditional thought face-to-face visits, which is your office visits and your inpatient services. And since office visits are already out of the question, we're really just looking at consults, home visits, or visits to patients' place of residence, such as a domiciliary site, and your inpatient visits, such as hospital, observation, and skilled nursing. If the type of service requires to know if a patient is new or established, that's when we get to this little table here, where we identify, is the patient seen within the office by the same provider or the same specialty within the last 3 years. That's what this decision tree identifies here. What this basically means is that anybody in your provider's office that is of the same specialty is considered as the same provider in the sense of new or established providers. So it's very important to know if your specialists in the office have a secondary specialty, because they could also be considered part of the same specialty as well as their specialty, if that makes sense. So we have here a patient that is not seen in the office or has not been seen in the office within the last 3 years by the same specialty, sorry about that scroll there, is a new patient. But if they have been seen within the last 3 years or have been seen by another provider in the office or the group of the same specialty in the last 3 years, then they are considered established. And you want to identify how you're going to bill them. There's some coding tips and some guidelines about that. And all of this information in front of you is also found directly in your CPT code book. In fact, on page 7. Time is another element that can be looked at in the CPT code selection. In most services, time-based billing can be used instead of key components that are required for the level of service when the time can be documented for counseling and coordination of care. There's a couple of strict guidelines about that, like stating the time specifically spent and showing that greater than 50% of the actual time spent was in fact counseling the patient or their family or doing other services as appropriate with that type of service. And there's differences between inpatient and outpatient. And some services like ER visits or emergency departments don't care about looking at time. I have other videos that talk about time in a more detailed and complex way. Make sure to take a look at some of those videos to see how time applies in different areas, not to mention the new time guidelines for office and other outpatient services. There's also some specific guidelines when looking at certain services like consultations, that it's important to pay attention to the type of service and the guidelines for that, which are usually in section guidelines. Essentially, when you're looking at a consult, the patient is not going to be continuing care with the provider providing the service. And in fact, a previous provider has requested the consult, sent the patient for services, and is going to be receiving the patient back with the recommended treatment of care. If the new provider performing the consult is taking over that care or has decided to continue seeing the patient, then it's considered a referral rather than a consult. And so they've taken over that care. There's a couple of other information that is relevant to the visit, such as the concurrent care and transfer of care services, which have some unique codes that can be used. Counseling and how it's reported for different types of services, both in the evaluation and management section, but also as modalities in the medicine section, and services that may be reported separately. Once you get to the guidelines for levels of E&M services, we look at the key components for most services. Now they've actually put everything in here. So they've talked about everything that's kind of included in all of the services. You have your history, exam, and medical decision-making, which has some definitions here to help you identify what goes into each of those sections. Now, this video is not intended to go in depth on what to use to select a level of history, exam, or medical decision-making. For that, you'll want to check out one of my other videos where we go into specifics on how to select history, exam, and medical decision-making from your note. For this video, we're just looking at the key components that are part of the E&M service, so I'll be skipping over some of these guidelines. Counseling and coordination of care, as I mentioned, are all part of time-based billing when we are using time in lieu of key components. And nature of presenting problems is a new reference that's being used in order to identify the types of problems that are being seen. As we continue forward and as we look at some of our other reviews, we'll look at those in more depth. So, how do we select the level of service? The first thing we do is we determine the extent of history obtained. In some services where history is not necessary, then simply saying that a relevant history was collected is all we need to state. However, if you're looking at some of the services that require history as a key component, you have 3 levels of history that you might look at, which include problem-focused, expanded problem-focused, and comprehensive. Let's take a step back and say, yes, there are in fact 4 levels, because oftentimes you'll see detailed included in this. The exam is often the same types of leveling where you have problem-focused, expanded problem-focused, detailed, and comprehensive. And as we look at the specific services, not all of them have the same levels mandatory for selecting the level of service. But it's important to remember this order so that you can say what is the highest level of history and exam versus what is the lowest level. With medical decision-making, you have a chart here which includes straightforward, low complexity, moderate, and high. And the medical decision-making is broken into 3 different areas, which changes depending on the type of service that you're looking at. With office and other outpatient services, there's brand new guidelines for medical decision-making selection that apply. For everything else that uses medical decision-making, we look at number of diagnoses and management options, the amount of data and complexity that is reviewed, such as how many tests were ordered or labs versus radiology, and the risk to the patient of complications that may include morbidity and or mortality. For this video, we won't go into some of the details of selecting history and exam, but in your guidelines, you can find a lot of the definitions that are used in some of the terms that will be identified throughout the guidelines in selecting history, exam, and most importantly, medical decision-making. These guidelines can help coders to clear out any gray areas and really make it clear as to what we're looking at when we're selecting a specific level of service. As I mentioned earlier, there's different guidelines for office and outpatient services, and that's what these are here. So we're going to keep going and get out of our guidelines for office and other outpatient E&Ms. Again, I'm going to continue moving forward past the section for office and other outpatient E&Ms. However, be aware, medical decision-making or time are the 2 components that are looked at for office and other outpatient services, which will be covered in detail in my video on office and other outpatient services for 2021. And as always in your coding guidelines, the last thing that you want to look at is the list of unlisted codes, which can be used in the instance that a service is not clearly identified in the options available. Unlisted codes should be a last resort after a coder has looked at all of the potential coding. And you can see here that there are 2 different types of unlisted codes, one for preventative and one for other types of evaluation and management services. So they're pretty straightforward. There's special reports and references of the clinical examples I mentioned earlier, which are found in Appendix C of your CPT codebook. At that point, if you're flipping along in the CPT codebook, you should be on page 18 if you're in the 2021 edition, where you'll see information for evaluation and management, office, or other outpatient services. Now, there's some in-section guidelines, which in the 3M world, we don't see directly here, but if you click on more information, you can find all of the details for in-section guidelines that would typically be found to a specific section as shown on the screen. You can find coding tips related to this type of services, which identify certain things such as professional services, definitions, and areas that are typically coded incorrectly based off of data and statistics. There's also details here on your new patient, identifying that a code has been deleted, which is the 99201 that was previously used to identify brand new patients that were of a level 1 visit to the office and other outpatient services. We now start in new patient services, as you see here, at a level 2 or 99202. And these all relate directly to your codebook, which is why I love looking at the electronic version with you. The last thing here is the table that you can select. And now this table is the same table that I mentioned found on Roman numeral XXV or Roman numeral 25 in the beginning of your CPT code book. In addition to the tables for office and other outpatient services, there's several tables for different types of services. So let's get into the meat and potato of this video. When we're looking at selecting a level of service, we have to identify first what is the type. The type of service is dependent on the location and information that we've covered so far, such as are they new or established, or in some cases, is this their first visit in a certain setting, or their last, or subsequent care. We'll look at that in just a moment. For office and other outpatient services, For a new patient, we can see on this table specific information related to this. A patient that is new has 4 codes, which all have specific requirements identified with the X's below. They also have time-based information that's also found in your CPT code. Some people prefer to look at just the text instead of the tables. And if that's you, that's okay. You can see the same information here by reading through the paragraph that an office or other outpatient visit for E&M of a new patient requires medically appropriate history and/or exam and straightforward medical decision-making if it's 99202, or time spent of 15 to 29 minutes. You can see the differences between a 202 and a 203 here, with the low level of medical decision-making and a different selection of time. 204, which includes a moderate level of medical decision-making and a different level of time, and a level 5 or 99205 that requires a high level of medical decision-making or a different specification of time. If I go back to this table, I can see all that same information here. Oh. It's just kind of spread out for me. Any level of history or exam is appropriate for any level of service. For a patient that requires all of the medical decision-making leveling to be met at either a straightforward, a low, a moderate, or a high, will determine the level of service. And we can see that by scrolling up here. You can see that these are both required elements. The medically appropriate history and/or exam simply says that it's medically appropriate. That doesn't mean that the provider should not document specific information about their history or exam. It means that the provider should have whatever they deem is appropriate, and what's appropriate is not measured in selection of the CPT code. When we look at the next level of service for 99211 through 99215, or office and other outpatient services for established patients, we can see that here at the top of our screen. We can also see that there's a new table for this type of service. And like the one before, it tells us for office or other outpatient services for patients that are established, the codes that apply, the required elements, which include a medically appropriate history or exam of any level, including one that is not applicable, which is used for your nurse visits only, and medical decision-making of any level, or basing your visit off of time. And again, we look at those in detail in a different video talking about office and other outpatient services and the 2021 guidelines. If a patient is determined as an observation patient, that means that they are in the hospital, but in an observation status. So they're not in the ER and they are not considered admitted to the inpatient setting. They may be in an inpatient wing or in the ER, but they're strictly under observation, not just an ER visit. In the inpatient world, it's required to have 2 things to be considered inpatient. There has to be both documentation that the patient is being admitted and expected that the provider believes they will be in the inpatient setting for 2 or more midnights. Meaning that if I am going into the hospital at 9:15 p.m. and I am there for 2 days past 2 midnights, then I could be considered inpatient, so long as the other part is documented, which is an actual admission to the inpatient ward. That means the provider has admitted me. If I'm just in observation, the day that I am discharged, if it's not the same day as my initial visit, is going to be coded with code 99217 for observation care discharge. These are per day codes for all of your inpatient services, as opposed to new and established services like we saw in the outpatient setting. For an observation care discharge, this means that there have been previous days that were billed as inpatient observation initial and or subsequent if needed. There's 3 different types of patients that are in the inpatient or observation status, you have your initial visit, which is the very first day they're seen, your subsequent visit, which is each day in between the initial and the discharge date, and your discharge visit, which is sometimes time-based. You can see here by reading through the blurb or paragraph that observation, care, discharge, day management is used for all discharge from outpatient hospital observation status if the discharge is on other than the initial date of observation status, meaning simply that they've been in the inpatient setting or the hospital setting rather, under an observation status for at least 2 days. This is on their second or further day. To clarify, we have an entire section devoted to initial observation care. Now, an observation patient is one who has not been admitted to the hospital and or has not stayed past that 2 midnight time frame. They may have been admitted to the hospital and expected to stay and they left early, or they perhaps perspired. In that instance, we would bill the initial observation care on the first day that they were in the hospital setting to identify they were in observation care on that initial day. There is a table here, which we can expand, and we can see initial observation care does not care if the patient is new or established, but it does have requirements that all 3 key components must be met at the highest level in order to bill a certain level of care. You can read these in the table by seeing that there's 3 levels of service for observation of care, for initial observation care. Those 3 levels are 99218, 99219, and 99220, which you can see in the background on the screen. Those 3 of 3 key components are identified here. History and exam 1 and 2 can be either detailed or comprehensive or just comprehensive. Your medical decision making, number 3, can be straightforward or low, moderate, or high. And you'll notice that we don't use all the levels available in this example. There's also some guidelines for time-based billing, which we go over in a different video when we talk about time. So if I'm looking at this, I can see the same information by reading the details under observation care in my CPT code book. That's going to be found on page 20 under hospital observation services, which has some in-section guidelines that you can see here by clicking on more. You can also see details about new evaluation and management observation, new or established patients here. So for an initial observation care, 99218 requires these 3 key components: identifying detailed or comprehensive history, detailed or comprehensive exam, and medical decision-making that is either straightforward or of low complexity. There's also information here about what counseling and coordination of care includes and the amount of time that is typical to this type of service. Since we're not looking at time or counseling and coordination of care, we're just looking at this first half here, which is selecting the key components to determine the most accurate level of service. For 99219, we have, again, the 3 key components. Now, I'm going to let you know, this doesn't change between types of service. So if I have defined the patient as a type of service as observation care, meaning they are in the hospital, they are not inpatient, and we are not billing for the ER, they are observation, and it is their first observation care date, which is not also a discharge day, then I am in these 3 codes. That is the type of service, initial observation care. And all 3 of these will have the same 3 component requirements. The changes between these 3 will be the level of history, exam, and medical decision-making and time. Everything else in these 3 levels of service under this type of care are the same. And this type of care is identified here at the top as initial observation care and is identified in your code book with red sections for this particular area. So a 218 is detailed or comprehensive history and exam with low medical decision making. A 219 is comprehensive history and exam. Notice that 218 can be either or, detailed or comprehensive, but 219 must meet a comprehensive level of history and exam. And medical decision making is of a moderate complexity. And then a 99220, which is your most severe initial observation visit, includes a comprehensive history and exam and medical decision making that is high. That seems pretty straightforward. So if we have a patient who has a comprehensive history and exam and medical decision making that is moderate, we would look at each of the three components and see that any of the three components can have comprehensive history and exam. But the third key component that is required is medical decision making, and we must select the level of medical decision making that is moderate. That would be a 99219. Now let's say, for example, we have a patient that has detailed history and exam, also with moderate medical decision making. At that point, you would say the highest level I can code with a detailed history and exam is a 218. And even though the medical decision making is lower than the level of medical decision making for moderate complexity, the moderate complexity medical decision making, or any of these key components, includes the requirements needed to meet the lower level. So in this example, a patient with moderate complexity of medical decision making also meets the requirements for medical decision making that is straightforward or of low complexity. We will look more at that in a moment. Let's look now at subsequent observation care. Again, we have all the same kind of guidelines that are available. We can look at the in-section notes that are available in your CPT code book. We can look at more information as well as the legend, which tells us what the symbols in the book mean, such as this little hashtag or pound symbol indicating that this is a resequenced code. And we can also look at this table. If you're a table lover like I am, again, this is found on Roman numeral 25 or XXV. And it is really great when selecting the level of service because I can just come in here and kind of check mark off and have a visual of each area and what is met. Okay, so looking at subsequent observation of care. This means first that I have identified that the patient is in the hospital setting, that they are not admitted to the inpatient status. I am not billing for the ER or other specialty visits. I am just billing for observation, and it is not the initial date, and it is not the discharge date, and it is not an initial and discharge date. So meaning it is in between both the initial and the discharge, and the patient has not perspired. So once I've identified the type of service is subsequent observation care, I want to look and see what are the required components. Now remember, I made a little E&M decision tree earlier, which said if I'm looking at an E&M that is not type of service for office and other outpatient or time or preventative based, and does not require new or established patients, but instead is observation inpatient or other types of inpatient services like SNF, then I'm looking at either initial, subsequent, or discharge patient. And this patient requires two key components. That's my table that I put together. But I can see all of that same information here by looking at the E&M table that identifies the level of care for subsequent observation care on a patient that is either new or established, they don't care, requires two of the three key components. And those key components are identified in my table as interval, history, and exam, which are number 1 and number 2 of those 3 key components, and medical decision-making, which is number 3. We have 3 different levels that we'll be looking at of each when looking at subsequent observation care. That includes problem-focused, expanded problem-focused, and detailed for history and exam. And you'll notice the term interval, history, and then medical decision-making that is either straightforward or low, moderate or high. And we can see that same information here. The subsequent observation care for 99224 through 99226 all have the same description where it says per day evaluation and management of patient, which requires at least 2 of these 3 key components, and specific information on counseling and coordination of care, as well as the amount of time. The changes are the level of history, exam, and medical decision-making, and the amount of time that's listed for each level of service under this type of service. So I can see here that the history and exam are both the same level for a level 99224. They're at a different level, but the same together as each other on a 225, and at a different level, but the same together again for a 226. And when I say that, what I mean is they're both problem focused for history or exam. They're both expanded problem focused for history or exam, and they're both detailed for history or exam. So each of these has the same requirements for history and exam of the same level. Medical decision-making, however, is different. Medical decision-making that is straightforward or low complexity would not meet any higher than a 99224. If the medical decision-making is of moderate complexity, that would meet for a 225. And if it is of high complexity, it would meet for a 226. One thing to keep in mind, because this only requires 2 of the 3 key components, the lowest level of key components can be ignored. Not so much ignored, but not used in selecting the level of care for this particular type of visit. Which means if I have a patient that has a detailed history and exam with medical decision-making that is moderate, I can find the highest level that I can code for either of those. The detailed history and exam falls under a 226. Since medical decision-making of moderate complexity is lower, I would not need to code a lower code because I only require 2 of these 3 key components to meet the need or requirements for a 99226. If this had been a visit that required all 3 key components though, I would have to code it lower because I would need to meet all 3 of those. So that's really important when you're identifying the highest level of care. It's based off of 2 of the 2 highest of the 3 key components. Let's look at our next type, which is initial hospital care. If you're coding for an initial hospital care, that means you have identified in the documentation that the patient is admitted to the hospital and or that they are admitted and staying past the 2 midnight rule. The 2 midnight rule again means that they are expected to stay past 2 midnights during their hospital stay. And this may be billed prior to those 2 midnights if you're billing concurrent care, meaning at the same time that they're being seen. But if you're in a billing office and you're submitting patients who are in the hospital and the patient leaves care prior to that 2nd midnight being met, you may end up having to make a corrected claim because they no longer meet the requirements for a hospital stay. That being said, we're learning about coding, not billing guidelines. So while it's important to be aware that sometimes we may have to go back and make changes, the most important thing here is to identify the type of service and the requirements for selecting the correct level of service with hospital patients. Here we have a hospital inpatient care for a provider that's billing for their professional services, which is for the initial hospital care. That means that there is an admission to the hospital on file, expecting them to stay past 2 midnights, and it is their initial or first day in the hospital setting. That doesn't mean it's their first day in the hospital, especially if they were already under observation. They may not even know that there was any difference between their setting going from observation to hospital admission. Oftentimes we will move them to a different location, but depending on the level of care needed for them in the observation setting, and depending on what we had available in the hospital that day, they may have already been put into a room. The initial hospital care visit is billed for your provider for all of the services they performed on that day while the patient was under their care. Only one provider per specialty can bill a hospital visit per day. So if they're seeing multiple specialties, they may be able to bill for initial or subsequent consults in the inpatient setting, or they may be billing for the type of service on the day that they saw them. The initial hospital care per day requires all 3 key components, and we can see this in the table here. We can see initial hospital care for a new or established patient requiring 3 key components. And I like to call these a level 1, 2, and 3 because the last digit on these codes ends in 1, 2, and 3. So 99221 or level 1 requires a detailed or comprehensive history and exam and medical decision-making that is straightforward or low. The contributory factors or presenting problems of severity tend to also be low, but this is not a requirement for selecting the level of service. I can see that same information here, that a detailed or comprehensive history and a detailed or comprehensive exam are required for a level 1, and medical decision-making that is of straightforward or low complexity. There's other information like counseling and coordination of care and time documentation in my code, just as there is on all of my E&Ms, or at least all the ones we've seen so far. For level 2, 99222, we have a requirement of a comprehensive history and exam with medical decision-making that is moderate. And for level 3, we have a comprehensive history and exam as well, so that hasn't changed, but the medical decision-making that is high. So let's play with this for a minute. Let's say you have a patient that is in the office that has a detailed history, a comprehensive exam, and medical decision-making that is of low complexity. At that point, we would come here and say a detailed history, a comprehensive exam, and medical decision-making of low complexity meets the requirements for 99221. Now, let's say we have a patient that has a comprehensive history and exam with medical decision-making that is moderate. At that point, we would come here to a 99222 or a level 2, where we have a comprehensive history and exam with moderate medical decision-making. Now let's take that same patient and say we have a comprehensive exam and moderate medical decision-making, but they were unconscious, and so the most history we could collect was detailed. In that case, you have to code based off of the highest level met by all 3 categories. And so I like to refer to this as coding based off of the weakest link. The weakest link is the lowest level of the 3 key components that we have and where it falls. In this case, the lowest level is history because it's detailed. The highest we can code for a detailed history is a 99221. And so even though we have a medical decision-making that is moderate and a comprehensive exam, which also meets for a 221, the moderate medical decision-making is much higher. And so we have to include or think of it as medical decision-making, or any of these levels that are higher also include the lower levels, which means that a moderate medical decision-making includes the same requirements to be met for a straightforward or low complexity. And therefore, all 3 of these key components are met since the medical decision-making is of at least straightforward or low complexity or higher. The detailed history, of course, is here, and the comprehensive exam is already here. Let's look at that again, but with subsequent hospital care instead of initial inpatient hospital care. Let's start first by looking at subsequent hospital care as a type of service. This type of service means that the patient is admitted to the inpatient setting. We're billing, of course, for the professional-based services for our provider, who is seeing them on a subsequent visit date. So it is not their initial date to the hospital, and they are not being discharged. We have identified that they are admitted and that they have stayed or are expected to stay past the 2 midnight rule. We can look at some of the information that pertains to subsequent hospital care. We can see coding tips about this type of service, which at times may be the same as some of the coding tips we've already looked at with previous E&M services. And we can see the unique table that is identified for subsequent hospital care. This is also again found in the tables in the beginning of your CPT code book. You'll notice there's 2 tables here in this reference because there's neonatal or pediatric critical intensive care tables that will apply for patients that are identified as neonatal and pediatric. For our patient, we're looking at just subsequent hospital care. And so we're assuming, or rather we're determining that the patient is not neonatal or pediatric. A subsequent hospital care does not care if the patient is new or established and does require 2 out of the 3 key components. Those key components being history and exam numbers 1 and 2, and medical decision-making. Since this only requires 2 of the 3 key components, that means I code the 2 highest of the 3 key components that I can meet. I have a level 1 or 99231 for subsequent hospital care, requires a problem-focused history and exam with medical decision-making that is of straightforward or low complexity. A level 2 or 99232 requires expanded problem-focused history and exam with medical decision-making of moderate complexity, and a level 3 for 99233 has requirements for detailed history and exam and high complexity of medical decision-making. Now, if all 3 of these key components meet the level of service, I have no issues. I can say an expanded problem-focused history and exam with moderate medical decision-making is for sure a level 2 99232. But if I have a higher level, I want to make sure to take some time to identify how many key components I need to meet to see which one I'm at. So let's take the example we said earlier of a detailed history, a comprehensive exam, and a medical decision-making that is moderate. You'll notice that comprehensive is not one of the exam options here on these particular codes. And so it's important to know if a patient has a comprehensive exam, is that higher or lower than what we already have available? A comprehensive exam is actually higher. It's the highest level of exam we can identify in our documentation. And therefore we would have, instead of a comprehensive, we would meet all of the requirements for a detailed exam, expanded problem-focused exam, and problem-focused. A detailed history also meets for a level 3 99233. However, a medical decision-making of moderate complexity only meets for a 99232. This is the exact same example I gave in our initial hospital care, where a detailed history, a comprehensive exam, and medical decision-making of moderate complexity only met a level 1 initial hospital visit. In our subsequent hospital care though, a detailed history, a comprehensive exam and lower, and a moderate medical decision-making will actually meet the requirements for a level 3 99233. Because only 2 of these 3 key components is required, and we've already met the level of history as detailed, We've already met the level of exam as detailed because detailed is included or met through the requirements to meet a comprehensive exam. And although our medical decision making is lower, it's not required since we've already met two of these three key components. Therefore, our code is 99233. That's it for this video. There's a couple of different areas that have very specific requirements, but as you go through the E&M coding section, you should be able to determine exactly where they're at. It's important when you're looking at your CPT code book to look at the specific requirements for each level of service as they pertain to how many key components and if they have unique key components that must be met. Of course, if you have questions, you're never alone. You're welcome to reach out to me at any time and email me at mgrant13@cnm.edu, or you can reach out on this video that you're watching, and I'd be happy to help you with any questions you might have. Thank you very much and have a great day.